should I say good evening. The very fact that few of you have still are there shows the keen interest that you have, or you are actually forced by one of us. Whatever may be the reason for you are here, I will try to make it as lucid and as simple as possible to sort of try to look into challenges pertaining to a problem which is very persistent. What we think to be something which is very easy to us, and I'm talking about us ENTs, not talking about the pedodontists who are amazing in this field. I should go on record and say that. So without further ado, I think we have a wonderful panel here, and I would go in order and probably ask questions. All the pictures and videos here have been consented for. As far as pediatric OSA is concerned, when you look at it from an India standpoint, 9.6% of school-going children have OSA. And the moment you bring in syndromic children, that is children with Downs, craniofacial, actually the plot thickens because the number keeps going up. And according to the gold standard, like for adult OSA, the gold standard is, all of you are very tired, CPAP. For children, the gold standard is adenoidectomy with or without tonsillectomy is the mainstay of treatment, right? All of us can stand here as ENTs and have a gorilla moment about it, right? Can beat our chest as a gold standard. But if you look at the percentage of success, 15 to 33% of children have persistent symptoms in spite of an adenotonsillectomy, right? That's a high number. So if there are 100 children that are coming to you, and if you offer them, and they all have symptoms of, sleep-related breathing disorder, you don't know which among them are the 30%. So quickly, I'll ask each one of you, in your practice, I just want yes or no, and in your own work, have you seen failures of adenotonsillectomy when children come with sleep-related breathing disorder, yes or no?
Yes, sir.
And what
Yes,
percentage?
I would say at least 3 to 4% of children, sir.
So you are giving a 97% success rate.
That's right, yes, sir.
So
I'm talking about overall percentage, not
we are
just my patients.
talking about, no, your patients, patient that walk into your clinic,
Yeah.
you have diagnosed based on the symptom to be having SRBD, and you have done a adenotonsillectomy based on the evaluation that you could do, and your judgment was question mark. What is the percentage of success?
About 10%.
10%. So you're giving a 90% success. Yeah. Sir.
Actually, I am facing failure rates around 10 to 15%.
Okay. Yeah. I'm glad it's increasing.
Sir, for me, it's only maybe 5 to 10%, not more than
5 to 10%.
90 to 95% gives a success rate. Right. And it will be a temporary, they will be having relief. Only after 1 or 2 months, they come back with the symptoms. It will be a recurrent of OSA. Like.
Yeah, we will come to those. Come on.
See, it's a lot about subjective, but if you look at objectively, we've done a study with sleep questionnaires.
No.
It's
I'm
about 20%. Based
that.
on the questionnaire.
Just a blind number.
20%. Based on the questionnaire, 20%.
Ma'am, you've seen a lot of this.
I always thought mine was very high till we actually did the numbers as a thesis.
Right.
And it is 25%, we have published it.
That seems to be a more, and also because institution practice is very different from private practice. So, of course, most of the complicated cases tend to get, so because I'm talking also about the syndromic cases that you must have seen. So the number is all over the room, right? So you're not sure which of the patient is going to succeed and which of the patients, and we'll discuss that a little later. So by definition, what is persistent OSA? This is it. Persistent OSA is unresolved OSA symptoms. And if you have, and according to the paper that's published in the American Thoracic Society, if you have an AHI of more than 5, it's considered persistent OSA, or if you have an AHI of more than 1.5 with symptoms, it's called persistent OSA. With symptoms mean any of the symptoms that the patient has come to you with. Now, I want you to pay attention to this video again, please. This is a patient, teenager, okay, the volume is not there, please imagine the sound in your head. Adenotonsillectomy done 6 months ago. That's why I said if they can.
You can hear the sound, not the video.
They'll get neck pain. That's what I'm saying, if they can just, so here's a child. That's easier, I can also look at them and. So, teenager, school-going kid, adenotonsillectomy done, gold standard, and I think we will start from the private practitioners and then go to institution. So, let's start from you because you are in the corner.
Yes, sir.
And this child, teenager,
Yeah,
gold standard therapy done.
yeah.
The mom sends horrific video again. Ryan is already smiling as to there are 100 things that are wrong there. But this is for our regular ENT guys. What is it that you observe? I want you to describe the video. And all of us ask for videos, right? Videos are very, very useful. So what is it that you see here with this child? What is wrong?
We're seeing the child sleeping supine position, snoring, and it looks like this child has some apneic episodes as well. And post adenotonsillectomy, this is the scenario. So it's very disturbing, number one, both for the parents and for the treating surgeon. Now, how do we handle this situation?
That is
Yeah, if you look at the child.
What do you think is
Yeah,
wrong?
so the child has got an adenoid face. He's got crowding of teeth, very poor
One.
competency, oral competency, and probably the
What is the pattern of breathing? Increased work of breathing.
yeah,
We do see a terrible malocclusion,
yeah,
and we do see a little bit of retrognathia,
yes,
right? And I'm sure you all must have seen this,
yes,
right? And this is the sleep study. Okay, this is a watchpad study for those of you who are familiar. Basically, AHI of 34 pre-op, post-op 5. From your standpoint, we just finished Saud's talk about disease burden. Yes, you've been successful in reducing disease burden. But do you think, have you done enough for this child?
This is the pre and post-op?
Pre and post
Before
watchpad
adenotonsillectomy,
study,
okay.
absolutely.
So I don't agree with this.
Huh?
I don't agree with that. With the pattern, the child is sleeping. With AHI 5 after surgery, the patient is still having the symptoms.
AHI is only actually 1.3. It's the
Oh.
RDI which is higher, which is the case in most pediatric
Pediatric
cases. So, have we done enough? Or does it need evaluation?
It needs evaluation, so the child needs to go for a sleep endoscopy.
Sleep endoscopy already.
We need to find out what is the other problem which is causing the airway collapse.
Okay, so I'll draw your attention to, there are so many other things that are wrong there. Don't you think we need to send the patient to somebody like Ryan?
Of course.
There's another child, very sweet boy. AHI 17.7, pre-op, post-op 11.3. Now, I have a small thing to say. The gold standard for evaluation in pediatric OSA is level 1. But the British Thoracic Society has recently released their recommendation last year, saying that in the absence of level 1, now the reason being we need to have ETCO2 for every sleep study you do in children, ideally, for reasons which are obvious. Now, in the absence of that, we can go ahead with at least some kind of cardiorespiratory parameters, and that's where this is, before you jump and shoot this thing at me. So, ODI, AHI. Now, this guy looks pretty decent, right? Have we done enough? Yes, we have reduced the disease burden. But in terms of severity, 17 to 11.
It's very minimal, it's not
So,
reduced at all.
according to the pediatric scale, we are still in severe, because after 10, it is severe.
Severe.
So, there are kids out there floating like this with different kind of manifestations. So I'll start from madam there. Do you think, ma'am, that pediatric OSA presents the same way across age groups? How does a school-going child, how does an infant, how does a toddler, how does a preschool present differently when it comes to how the parent and the child comes to an ENT surgeon like us? Do they come with a typical snoring, excessive daytime sleepiness, how an adult presents? Or the game when it comes to pediatric is very different?
See, if many of the parents do come as, they say, not really snoring, many times they say this, you have the small snore and the gasp and the choke, that cycle. And in fact, I had one patient, one father and mother came, the father is carrying a stick with him. I said, why do you carry the stick? He said, I have to put a stick in the mouth to make him breathe. So you do have suction. But the younger the child, many a times, it's not this, you know, they have sort of symptoms in the daytime. They're very hyperactive and not like adults, the daytime sleepiness. So they have a child which is behaving differently, hyper to hyperactive. These are few things. It should go in the back of your mind. Is it an obstructive element or something else? Obstructive element is the easiest to pick up if you know how to look and see the patient.
As they call it, the low-lying fruit, as they call it.
So is it something else? Then you have to think twice. That is where the dilemma comes. And you see an associated, tonsils. Agreed, you have to address it because you cannot go to the next step. But at least we can warn the patient's parents or what some other telltale marks are there. Probably we should do, it may not. So at least an expectation of...
But at least you should do.
Yes, you have to.
Dr. Kamaran, what do you think about, I would like to ask you, because you're in a specialty center, especially kids with, toddlers who come with persistent malbreathing, preschool children with nocturnal enuresis, and I would like you to talk a few words about ADHD and OSA.
That is there. So a lot of kids who come with hyperactivity, not able to focus on one thing, are being restless, are climate being a nightmare for the parents. But sometimes these kids are referred to us by developmental pediatricians.
Right.
So they look at something which is not truly fitting into ADHD. I mean, they usually are referred by pediatrics to developmental pediatrics to assess for ADHD and all that. They get sent to ENT saying that this is not fitting into classical ADHD. Can you look at that?
Sir, what is your experience?
So actually, in infants, we will receive poor feeding, poor breast intake. In toddlers, we are receiving patients in mouth breathing and dribbling of saliva. These are the common...
More often when the parents come to you with saying that the growth curve is not being stuck to
Yes,
in
sir.
terms of percentile,
Yes, sir.
would you jump and say, I think this is it, and go and do something, or how would you approach that parent
actually I was-
whose main complaint?
I will suggest this is the one of the reason for our children's development delay. Maybe this will help for the development improvement.
Sir, what's your experience?
Sir, mostly the cases will be referred by a pediatrician, very rarely for adenotonsillectomy. But what I see was a obese child presenting with the OSA having adenotonsillectomy. So I'll be skeptical in telling the prognosis how it will be after surgery. And
Very
also,
good, sir. We are going to come to that topic where our failures can go down, but particularly when it comes to, school-going children whose kids' grades are going down,
Yeah,
we are
poor
seeing
school
that quite
performance.
often because the pediatrician is trying to push it on
Talk to
us.
your ENT side.
And then we need to be careful
Yeah.
because if you commit, the parent is going to lock
Totally
you on
lock.
that word. And then there are other causes for this. This is also one of the cause, but that doesn't mean everything is our responsibility. Now tomorrow patient has urine problem, it's not your responsibility. Just because you have done an adenotonsillectomy for the child. So we need to be a little wary of that. So I would like to actually, even Ryan is not there on the panel, but I would love to have him on board. Ma'am,
No, I just thought, just one, because you put infants on top.
Yes.
The younger the child, it's definitely a not primary ENT or a tonsils adenoids. That should be at the back of your mind.
yes, and
A
that's where
cerebral-
sleep studies actually come in.
That's all I
And
just-
level 1 sleep study.
I just wanted to add.
Thank you, ma'am. Ryan, or maybe I should ask you to the end. First, I'll go with our ENT colleagues again, and then, so what is wrong with these children? This child just came and sat in the OP,
Yeah.
and I'm just looking at her. Can you comment on just what the body posture and face is giving away as a diagnosis? Actually, the child is screaming of the diagnosis.
Yeah, so child has got a receding mandible, even the mid face is also slightly,
The first kid, right?
yeah, the first one, the left.
First kid,
Yeah, yeah. So
What else?
stooping posture, it's got a child has got a stoop.
So if I may ask, I think I'll ask him, what else do you think?
She could have
No,
a
I think he's given half the answer.
pectus. She could have a pectus, the chest, flail chest or
Possible,
something.
possible. What do you think?
child is sitting and leaning forward, sir.
Yes.
So that there's a airway is
Exactly. Why do you think the child is leaning forward?
Oropharyngeal airway is
And the nasopharyngeal airway. See, that is why when you look at when you get a standard x-rays, when you do this to create that space when you get the x-ray. So that's the only way the child can breathe. So what happens? If the child has to breathe well, the child has to extend the neck like this. But can you walk like this? You can't. So what do? You extend the neck. So your posture becomes like this. So they are always like this, and then the moment they sit on the chair also, they are like this. So this is an airway problem. And Ryan,
Yeah.
can you please tell me what is all wrong with that child?
Yeah. So here there is an incompetent lip at rest.
Yes.
Okay.
Lack of lip
Yeah,
seal. Yes.
Lip seal. And the tone of the muscle could be a little hypertonic on the lower segment.
The mentalis
Yeah,
strain, as we
yeah.
call it.
So, and the lip, what do you see? The lip thickness
Yeah.
is a thin upper lip and a thick lower lip. Okay, so there is asymmetry in the lip thickness. And when you see, there could be a tone of the lip also could be little low to get a good lip seal. Okay, and when you see the facial profile of this patient, you will definitely have a convex facial profile.
Right. Exactly.
She could be a developing class 2 malocclusion
Perfect.
at skeletally not that bad, but on the, what do you say, an average kind of. She's a developing class 2
So
malocclusion.
all of this is even without us opening the mouth and the nose and anything before the child is even. So the moment they come, you already have the diagnosis as to what's going on. What's wrong with this boy?
You want me to say?
No, you will come towards the end. You are the expert. Probably we'll start with ma'am. Ma'am,
The frontal view, he's got a narrow chin, both the tooth protruding out, which sort of tells he probably has maybe a high-arched palate, maybe. And, lateral view I can see, correct. Protruding teeth, narrow mandible, convex.
yes, ma'am.
Profile.
That's exactly what he was talking about. Any comment on the jaw?
Yes, posture is again sitting a
The
narrow chin is a micronathia.
the jaw?
Micronathia, I said it.
It's
narrow
there,
chin,
ma'am.
yeah.
What about the direction with which the jaw seems to be growing? Our
Towards
jaw is like this. The
Yes.
jaw seems to
Good.
be,
narrowing
going
downwards.
down.
Downwards, correct.
that is very classical of an obstruction. And I would like your, for us as ENTs, this we are seeing again and again and again. Some of it unfortunately becomes, because a lot of times either the dental guys refer to us, from an institution standpoint, Dr. Kamran, what is your stand on ankyloglossia and sleep-related breathing disorder?
I mean, tongue tie per se, just alone for tongue tie, most probably we would not do it. But
No,
as
from
part
a
of,
sleep-related breathing
yeah,
disorder
as part of
perspective,
procedure, if you're doing tonsillectomy or something, then if it is there, we might do it, but not alone.
how would you grade your tongue ties?
Grade, we follow the,
Cotlos?
yeah, Cotlas, grade, four grades. So,
So that's the thing, right? So there is the Zagi one, which is called the TRMR, seems to be much better because this is a result of a persistent tongue tie.
Tongue
There
tie,
is nothing else because the tongue actually helps the development of the upper jaw. And if the tongue is in a low tongue posture, obviously there is nothing guiding because the muscles guide the development of the upper jaw. Shankar, how much time? 5 minutes, huh? 5 minutes. Okay. Sir, you wanted to talk a few words about obesity.
Sir, obese is a syndromic child. We have to think of thyroid profile and also the oropharyngeal airway and anesthetic complications.
Yes.
And also after extubation, how we are going to manage the child.
The reason being that the success rate, when you do the gold standard therapy for OSA, is abysmal 20 to 30% in an obese child. We should be very, very careful of that before we put, and nowadays we are seeing these kids, again, they're just floating everywhere thanks to all the fast food that's there. So, how many of us would really do a sleep study or a sleep assessment before doing an endotonsillectomy? What are your guidelines in your institute, and then we'll come to private practice, which is totally different.
So we only ask about the history alone, sir. We don't do a sleep lab test, whether the snoring is there and the symptoms
child?
associated with obstetrics.
Any child?
Not routinely, we don't do sleep lab studies, sir.
So, ma'am, what is it in the institute?
If it's diagnosed hypertrophied adenotonsillectomy, bioclinical and endoscopic, infective or non-infective, if an indication for infective is there or an indication for non-infective hypertrophied is there, we will go ahead unless the child physically looks other syndromes or some other telltale marks of associated illness, we will go ahead without a sleep study.
Nowadays in private practice, because of all the allergies, you come from the allergy capital of India. So there is a lot of allergy there, and we are seeing this in children. Children 2 years of age are sent to daycares, and there is a huge, because of the allergy that starts around 2 years, there is a lot of adenotonsillar hypertrophy that basically comes in. So if there is a child with severe symptoms, with the video showing that there is an obstruction, who's around 2 years, would you throw in a sleep study of some sort, or would you just go ahead, clear the low-lying fruit, and then take your chances?
Since I work with a pediatric sleep center, we are associated with the pediatric sleep center. So our indication for a sleep study would generally be syndromic kids. It would be post-T&A failures. Apart from that, a regular...
If there is a failure to thrive child.
No. Failure post-T&A, persistent OSA.
Post. So the recommendations according to thing are a little different. We are supposed to, if there is a child who's 2 years or younger, it's important that we do a sleep study. Why? Because there can be a lot of central components. So if once there is a central component to the sleep apnea, then you are in a fix, because you can only take care of the obstructive component. But yes, these kids don't come alone, but sometimes there may be some kind of a recessive gene that is not manifesting, which may come in and say, that's it. So now, you've already said what your indications to evaluate a child post-TNA. What would be your indications? So ma'am said she'll wait for 3 months before she does anything. What do you see? Parent has come back, your surgery, your child, symptoms are status quo. What will you evaluate?
So at the end of the surgery itself, on the day one itself, I'll tell them the child is going to have the same symptoms what he had prior to surgery for about a week to 2 weeks, and slowly everything will reduce in a period of 2 months. Even after that, it's going to be there. So we have to think about allergies, whether he is chronically exposed to
My
allergic
question
reactions.
is, will you evaluate, or
I will
when will
evaluate.
you evaluate? Like
the
how
end of
ma'am
2
said
months.
3 months. Yours is when?
At the end of 2 months, sir.
2 months. Sir,
The habituation of mouth opening should stop in 3 weeks, but
No,
the
no.
Chexcopy 3 months. 3 months.
3 months.
Yes.
3 months, done. So this is a chart of all the data that's out there. Okay, I want your interpretations on this, and this will be the last slide, okay, man? What I've done is I put all the data together from these papers and looked at what are the commonest causes, where is the, what level is the obstruction happening, and where are we really scoring very high? The highest seems to be at the level of the epiglottis. And I'll bring in Kamran into that a little later. But look at how high nasal airway is. So what do you think is happening there? Okay, this is understood, epiglottis understood. But why nose? Do you have a possible explanation to that?
The only thing that knows that is, one is the DNS, the other one is the turbinate hypertrophy, especially in the kids.
So I would want you to talk about,
Yeah.
if there is a child with a septal deviation at that time, with allergic rhinitis, you will manage that conservatively. If there is a septal deviation, what is your threshold to do a pediatric septoplasty? Very controversial, so I want to bring this up.
It depends on the severity. If it is severe, then as young as even 8 to 9 years, we would do a septoplasty.
Okay?
But if it's not a very high-graded DNS, then we'll probably stage it at a later. And if we are sure that that's not going to cause a predominant problem, we're going to leave it alone and do a proper septoterminoplasty after the age of, say, 13 or 14 years. Yeah.
Would you also think that persistent mouth breathing is causing the palate to go up, causing the septum? And
Yeah.
maybe we
So,
should
yes,
have a
yes,
help.
Yes. So post that, once we do the maxillary expansion, the septums do sometimes come down to the midline, and that also helps. Yes.
How many of you refer your patients to
All.
pediodontist?
All, yeah, almost all, yeah.
See, we are not that different.
In fact, I exchanged numbers with him as well.
There you go.
There is a small calculation
Please.
See, when we do maxillary expansion, we look at expanding the maxilla by about 3 mm or 4 mm or maybe about 8 to 10 mm varaikkum we'll try to expand. What the literature says is, we are trying to expand volume. What we are expanding in millimeter, you are gaining in percentage, the volume.
Correct. It's all about the nasal volume, which is a three-dimensional structure.
Yeah, if you're looking like a cylinder, it's like length into breadth into height. That's like 4 mm of expansion is like 4 into 4, 16, 16 into 4, 64% increase in the volume from the existing volume what the child is breathing. So there is a huge change which can happen, and there is a lot of literature to say that it can even control the nocturnal enuresis. Because the pathophysiology, the antidiuretic hormone secretion is improved.
It's important that we know that aspect of it too, so that you can fight this battle together. Dr. Kamran.
So one thing I wanted to comment about the multi-level obstruction, the table what you put. So there was a study during my fellowship in Australia which we did in DICE. So a lot of these patients who I saw had base tongue obstruction.
Correct.
So the study was on surgically naive patients undergoing adenotonsillectomy. So we did DICE and did adenotonsillectomy. But surprisingly, most of the children who we saw had epiglottic and tongue-based collapse did not come back with residual symptoms. So that was probably because of the upstream obstruction.
Proximal, and that's true in adult as well. It's a Bernoulli's phenomena,
Yeah.
basically.
So it was a false positive, but often the problem is the nose which we overlook. We don't treat the nose enough.
Exactly.
One more thing, just let me add. Like earlier, I mean, I've been trained nearly 40 years ago. We were always told adenoid facies is an indication for adenoid. But now we realize we do not wait for the adenoid facies. Because once the higher stallus is
Yes.
formed by the lack of airway,
Exactly,
your
the damage is done.
correction- Yes, damage is done. That's it.
Okay, Kamran. Any role of biomarkers in persistent OSA? Maybe you can just do that test and say, okay, this guy has persistent OSA.
I look at CRP, sir, to be honest. That is something
Yes, we have done the study also. So all of us can use highly sensitive CRP, and we have done one that we are going to present this time in Amritsar, wherein we've correlated high sensitive CRP with residual symptoms. In addition, there are also other markers that you can use as biomarkers for residual disease, so that there's a lot of inflammation that's happening if there is persistence of OSA, and that's about it. And I think we will stop it at this point, because I think this is, but thank you very much, guys. You stayed till now. I think hats off to you all. And thanks, wonderful panelists, and you all stuck to time, not too much. You have not been Micasurs, and you did not eat up the mic. So thank you very much for that.
Sir, just to take one question from the audience.
Yes, please.
Sir, I'll introduce myself. So I'm an orthodontist, sir. Usually regarding this rapid maxillary expansion, like one small thing I would like to tell here, that is we need to expand the maxilla within 15 years of age. That is, usually we don't get references from general doctors. Usually if they refer them by 8 or 10 years of age, 8 to 10, usually it's very much favorable for us to expand the mandible. That is, we use rapid maxillary expanders, and that is, we activate the screws and then we expand the maxilla. At that age, if they are going to expand the maxilla, there is so much benefit for the patient, that is functionally as well as aesthetically, as well as in biting, eating, whatever. So by 8 to 10 years of age, if they could notice and refer patients for the orthodontist or periodontist, it will be very fine for the
No,
management.
absolutely agree with you. But the catch there is the fusion of the mid-palatine suture sometimes, which unfortunately plays the spoil sport.
Yes, by 15 years it completely fuses, so that there's no benefit after that expanding the maxilla.
Yeah,
So,
yeah.
so that will be awareing if you can tell.
Thank you. Point
Thank you.
taken. Thank you all panelists. You've been really good sport. Thank you.
Thank you, sir. Thank you.